Welcome back to the session on February 2010 paper 2. Right now, the first question we are going to discuss today is hematuria, the causes of hematuria and how you are going to manage a case of hematuria in a 70-year-old male. Okay, now first we are going to enlist the causes of hematuria. I want to address the causes of hematuria in a simple diagram so that it will be easy for you to remember. Now, cause may be in the entire urinary tract. There can be anywhere. The cause can be anywhere. Maybe in the kidney, maybe in the ureter, maybe in the bladder, maybe in the prostate, maybe in the urethra also. So we will look into various causes. First thing is water in the kidney. It is divided into glomerular causes and obviously extraglomerular causes. Under glomerular causes, most important is glomerulonephritis. Other things you can write, okay? Thin basement membrane disease, IgA nephritis, or all of those. And even Alport syndrome can also present with the hematuria. Now, what are all the extraglomerular causes? Renal stones can cause hematuria, and even in sickle cell anemia, even in sickle cell also is a cause. Now, to remember in a better way, I am going to take TIN as a method to remember. What is TIN? T means tumor, I means infection, N means neoplasm. Okay, sorry, T means not tumor, T means trauma, I means infection, N means neoplasm. Okay, trauma, infection, neoplasm. So trauma to the kidney or infection to the kidney or even neoplasm of the kidney can also cause the hematuria. Now within the ureter also there can be ureteric trauma, there can be infection in the ureter. Okay, even sometimes neoplasm also can cause this. Even in ureter also stones can occur. Okay, and you already know ureteric stricture can also cause hematuria. Now coming to the bladder. Bladder also I am going to write the same thing. Trauma to the bladder, infection to the bladder, bladder cancer, that is neoplasm of the bladder. Bladder, in bladder also stone formation may occur, bladder stones. Okay. Now coming to prostate. You already know, again I am telling you, even prostate tumors can cause hematuria. Not only that, benign prostatic hyperplasia can also cause hematuria. Now coming to urethra also I am writing the same thing. Maybe trauma, maybe infection. Okay, all the places I am writing the almost the same thing. Trauma, infection and neoplasm. Okay, within the kidney, trauma, infection, neoplasm and stones. Coming to the ureter. Ureter also you can see trauma, infection, neoplasm, stones as well as ureteric stricture can also cause this. Coming to the urinary bladder, you already know bladder cancer can cause. Infection of the urinary bladder can also cause. Even stones in the bladder can also cause. Same thing, trauma, infection, neoplasm, stones. Now coming to the prostate. Prostate, one is tumor and the other is benign prostatic hyperplasia. Now coming to the urethra. In urethra, what you can get? You can get trauma or you can get infection. Okay, this is a simplified version of what you have to remember. So can pyelonephritis cause hematuria? The answer is yes. It is just one of the infection of the kidney. So the answer is yes. Can renal cancer RCC, can it cause hematuria? The answer is again yes. Why? Because it is a neoplasm. Okay. Can bladder cancer? Yes. Can renal stones? Yes. Ureteric stones? Yes. All of them can cause hematuria. Just I have explained them in a simple way so that it will be easy to remember. Trauma, infection, neoplasm, everywhere you can write. Wherever there is an entity of stone formation, you can always write stone formation there. Now, after enlisting the causes, we will move forward. So, hematuria is of two types. Hematuria means what? There is blood in the urine. It may be visible, it may be non-visible also. Sir, how it will be non-visible? If at all I see within a microscope, there is presence of RBCs, then what can I tell? Yes, it is also hematuria only. Presence of blood in the urine, it is also. That is microscopic hematuria. Okay. So the hematuria can be visible or it can be non-visible. Okay. Now, coming to the timing of the blood in relation to the urine stream is also guiding me in some way. What is the pathology involved can be guided by the timing of the blood. Suppose during passage of urine, if the blood is coming in the initial part of the urine, then the pathology is different. If it is coming throughout the urine, then the cause is different. If it is coming in the last part of the urine during micturition, then the pathology is different. We will look into them. So if it is in the initial phase, what is the cause? Can you guess what is the cause if it is in the initial phases? Yes, it is a problem in the urethra. It has to be a urethral problem. So if it is throughout the stream of the urine, if there is blood, then what problem it is? The problem has to be in the bladder, or the problem has to be somewhere in the upper tracts. Okay. If it is in the terminal part, please remember this. If it is in the terminal part, it has to be due to bladder neck. It has to be due to bladder neck pathology, or it has to be due to a prostate pathology. So if it is coming in the initial part, it has to be due to a urethral pathology. If it is occurring throughout the stream, then it has to be a bladder pathology or upper tracts pathology. If it is occurring in the terminal part, then it has to be what? Either bladder neck or a prostatic problem. Okay. Now we will move ahead. I have already told you trauma, infection and neoplasm are the things which are part and parcel of what? Hematuria. Now, under trauma part we will discuss separately in another questions. During trauma, I mean urethral trauma, urinary bladder trauma, they are all completely different entities. We will discuss them in the future. But now what we are going to discuss now, coming to infection. So genitourinary TB, how can I tell if it is due to infection? What are the features of a genitourinary TB? We have already said there is hematuria. Along with that hematuria, there will be dysuria in case of TB. Not only dysuria, there is also increase in the frequency of micturition is also there in case of genitourinary TB. Now coming to even filaria can also cause the same thing. It also can cause hematuria, which is an infectious cause. Now, what are the features which tell me, yeah, this is filaria? Means there is involvement of retroperitoneal lymph nodes. Retroperitoneal lymphatics involvement. You already know filaria is always about lymphatics, right? So if the retroperitoneal lymph nodes are involved, then I have to think in terms of filaria. Now coming to renal tumor, neoplasm. Under neoplasm I have written renal tumor. Can anybody tell me the features of RCC. There is a triad in renal cell cancer. Obviously, one part has to be hematuria. What are the other two things? Other two things are there should be pain. Loin pain has to be there, and there should be a mass, palpable loin mass. This triad is very important triad for renal cell cancer. But all the three features of the triad are seen in only maybe around 10 percentage of the cases. But the triad per se is very important. Okay, what are the three features of triad? Hematuria, loin pain, palpable loin mass. These are the three features. Now, any case of hematuria should always be investigated. Except if a young female is there with proven urinary tract infection. Young female with proven urinary tract infection, that is the only case where I am not investigating. Otherwise, all cases of hematuria has to be investigated. Now, one point I have forgotten to mention. In filaria, there is retroperitoneal lymphatics involvement. Along with that, you can see milky color of the urine, that I am going to call it as chyluria. Milky color of the urine, chyluria, is a feature of filariasis. Okay. Now, so whatever may be the cause, first thing is I have to investigate for what is the cause of this hematuria. So what is the first investigation I have to do? What is the first and basic investigation I have to do? Yes, you are correct. I have to get an ultrasound. So ultrasound of what? Kidney, ureter, bladder. Ultrasound KUB I have to get. If needed, I am going to perform some contrast imaging also, like CECT or something. I can perform a contrast imaging if needed. But the basic and the first investigation to be done is ultrasound, kidney, ureter, bladder. So I have done ultrasound or I have done contrast imaging also, but I cannot identify any cause for hematuria. Now what should I do? Now I have to perform cystoscopy. Okay, I have to perform cystoscopy. Now this is about the investigation part. So coming to older men, what is the cause of hematuria? Even sometimes benign prostatic hyperplasia occurs in elderly males. You already know. Even BP, we have already studied just now, even BPH can also cause hematuria. But whenever you are diagnosing hematuria which is due to BPH in an elderly male, the first thing is you have to exclude other causes. Why I am telling you this? Because many males or many elderly males are going to develop benign prostatic hyperplasia. We have to diagnose hematuria due to BPH only after excluding other causes only. Okay. Now, what is the management? How to manage a case of hematuria? Our question is how to manage a case of hematuria in the elderly. So, how to discuss this question and how to look at the management is completely different. Why? Because if the hematuria is due to glomerulonephritis, then the management would be completely different. If it is due to, already given in the question, it is more than 70-year-old, around 70-year-old, maybe BPH can also be the cause. If it is BPH, then the management is different. So if it is a case of RCC, let us take, then the management is completely different. Okay, based on what is the cause, you have to write. Means my humble request, if a similar question is asked, then it's always better to outline the management of different causes. It's always better to outline the management of different causes. Like you write few points about treatment of glomerulonephritis, few points on BPH, few points on RCC, few points on stone, like few points you can write. Especially the main cause may be BPH. That is why elaborate somewhat more about BPH and write other things in a brief manner. Now the next question they have asked is, so I have not discussed the treatment of RCC, BPH, glomerulonephritis, stones, everything I have not discussed here, but in the further videos when the question comes, I am going to discuss them individually. So that is the reason why I am not discussing here. Okay. Now coming to the nerve injuries. Nerve injuries, I don't think so. It is a general surgery question. It has to be a orthopedics question. But anyhow, they have already asked once. It's better to look at it. Now, nerve injuries. So these are the three types. I want to tell you, nerve injuries are of three types. So what are the three types we will look into? Suppose if I take a nerve, suppose this is a nerve from here, this is a nerve. Nerve is covered by what? Epineurium. Within that there will be perineurium. Within that will be endoneurium. So you already know there are three layers for a nerve. Epineurium, inside that perineurium, inside that endoneurium. Based on the involvement, we are going to divide it into three types. So what are the three types? First one is neuropraxia. Second one is axonotemesis. And the third one is neurotemesis. If you look at these three things, neuropraxia, axonotemesis and neurotemesis, can you tell me which is more dangerous? With common sense, you can tell me neurotemesis is more dangerous. Sir, why? All the three are involved and the nerve is going to be separated. That is why neurotemesis is much more. Coming to axonotemesis, only this part is involved, only some part is only involved, whereas neuropraxia is always a mild one. Okay, you can always study neuropraxia, axonotemesis and neurotemesis in orthopedics. Neuropraxia only it does not require any treatment. Okay. Now suppose there is an injury to the nerve. What happens? So suppose here there is an injury here, this part. Any part which is distal, anything which is distal to the part of the injury is undergoing degeneration. So any part which is distal to it, suppose this is the injury level, any part which is distal to it should undergo degeneration. What is the name of the degeneration? Can anyone guess? Yes, it is Wallerian degeneration. Now, whereas the proximal part, even within the proximal part, up to the coming node of Ranvier, there will be some disintegration. Up to the coming nodes of ranua, there will be some disintegration. Okay, this part will be disintegrated, but this entire proximal part have the regenerating capacity. Again, this proximal part is going to regenerate. In which direction it is going to regenerate means it is regenerating towards the receptors. It is regenerating towards the means this proximal part again grows towards the here receptors will be there. So again the proximal part is the one which is going to what regenerate towards the distal side, towards the receptor side in other terms. And the distal part of any part which is distal to the injury is going to undergo degeneration. We are calling that as Valerian degeneration. Now, I told you regenerating nerve fibers are regenerating towards what? Towards the receptors side. Why this is happening? This is due to a mechanism called neurotropism. That is the reason why it is growing towards the receptors. Some certain growth factors are required for this neurotropism. So coming to nerve injuries, I didn't go much detail into nerve injuries, but why? Because it is not a surgery topic. Just I have enlisted the three types: neuropraxia, axonotemesis and neurotemesis. And I have already explained you the three layers which are present within the nerve. And then we move on to the injury. What happens when there is a injury to that? The distal part is going to undergo degeneration called as Valerian degeneration, whereas the proximal part is going to grow distally towards the receptors due to a mechanism called neurotropism, which is requiring certain growth factors. Now, coming to suture materials. Suture materials, I'm not going to discuss each and every point about a suture. Okay, just I want to go through what are the desired characteristics of a suture material, and I'm enlisting few basic, only I'm telling you basic. I'm not going into depth. Why? Because basic is something which is required at your level. Okay, some basic points on each and every suture. Okay, now first thing is we are going to look at the desired characteristics of a suture material. So if I am going to use a suture material, then what I am going to look into? So number one, it has to be easy to handle. Okay, what is the first point given here? It should be easy to handle. Okay, now I should be able to know what is the behavior of the suture within the tissues. Okay, this is the second point. And the other thing is it should cause minimal tissue reaction also. Okay, and predictable tensile strength. If I use a suture, then it should have a predictable tensile strength should be there. If the tensile strength is not good, then it is of no use. Okay, now the suture should be easily able to glide. It should be easily able to glide through the tissues easily, and I should be able to suture that easily. If there is a suture material where the tensile strength is strong, the suture is strong enough, but I cannot make a not easily, then what is the use? There is no use. That is why secure knotting ability should be there for the suture. Now, and the suture should be inexpensive. Okay, last 2 points you can study. It should not cause any allergy and it should not cause any cancer. Okay, just briefly outline the main points. It should be inexpensive, it should be non-allergic, it should be non-carcinogenic, it should be easy to handle, it should have a secure knot ability, there should be enough tensile strength, and there should uh, there should be a predictable behavior in the tissue. There should be minimal tissue reaction. All these things you can remember. Now coming to the suture materials per se, the first thing we have seen is the desired characteristics of a suture material we have seen. Now we are coming to the individualized suture materials. Now suture materials I am dividing it into two types. One is non-absorbable and the other is absorbable. First we will look into all the non-absorbable sutures and then we will go to absorbable sutures. Now coming to the non-absorbable sutures. Under non-absorbable sutures, the first thing I want to discuss is silk. Coming to silk, what are the uses of a silk suture? Two uses, please enlist them. Vessel ligation, drain fixation, very important, drain fixation. Whenever you want to fix a drain, you should always use a silk suture. Okay, it can be used for vessel ligation as well as for drain fixation, that is silk suture. Then what is the problem with the silk suture? The problem with the silk suture is there is a risk of infection to this and there is a risk of tissue reaction also. So tissue reaction and risk of infection are the two main problems when we are using a silk suture. But where we are using the silk, one vessel ligation, two drain fixation. Just 2 points, remember them. Now moving ahead to nylon. Now what are the places where we are using a nylon suture? It has to be a cataract surgery. It has to be a cataract surgery. I have to use a nylon suture. For repair of nerves, I have to use a nylon suture. For repair of tendons, I have to use a nylon suture. Okay. Now coming to proline, you already know from your chemistry knowledge or biochemistry knowledge, proline is nothing but what? It is polypropylene or proline. Both of them mean the same. Now you already know in hernia, I think you have already studied, proline mesh is the one which is used in hernia, right? Proline is something which we are going to use for a mesh. Okay, tell me other use of this proline. It is used for vessel repair, very important. Okay, now before going to absorbable, just we will look into what are all the absorbable non-absorbable sutures. Under non-absorbable sutures, I have told you three things. First one is silk sutures, second one is nylon, and the third one is what? Proline. Under silk, I have already told you vessel ligation, drain fixation. I have already told you the problems with the silk suture. Risk of infection is there, and there is also tissue reaction. Coming to the nylon, nylon is used where? It is used in cataract surgery. Even for when you are dealing with nerves, when you are dealing with tendons, you have to use a nylon suture. Coming to the third one is proline, which is also called as polypropylene. Where we are using that? One is vessel repair and the other is mesh in case, we are using like a mesh in case of hernia or other surgeries. Proline mesh we can use. Okay, now we have seen non-absorbable. Now we are going to the absorbable sutures. Under absorbable sutures, the first suture I want to mention is catgut. So catgut. Please remember these catgut sutures are always used for a superficial entity. They are not used for something like a deeper entity. We are always using them for a superficial entities. Like whenever I am ligating superficial vessels, I am ligating. superficial vessels I am ligating, I have to use a catgut suture. Whenever I am doing suturing to the subcutaneous tissues which is also superficial, then I can use a catgut suture. Whenever I am doing suturing to a stomas or tissues which can heal quickly healing tissues also, I can use the catgut suture. Now I told you catgut suture is a absorbable suture. So how it is going to absorb? What is the mechanism by which it is going to get absorbed? Is phagocytosis and enzyme degradation. Please write it down. Right now, by how much time this is occurring means by how much time it is going to get absorbed within the body. I told you it is a absorbable suture. It is going to get absorbed within the body. But within how much time it is going to get absorbed? If it is a catgut suture, it gets absorbed within 7 to 10 days. If it is a chromic catgut suture, then it is going to get absorbed within 90 days. Okay. Now coming to Vicryl, which is nothing but polyglactin. I think it's hard to remember polyglactin. Simply you can remember Vicryl. General surgical use only, nothing much. But whenever you want to suture a tissue where stone formation is at risk, means what? Suppose I am doing a surgery which is related to the gallbladder, there is always stone formation is always a risk. Then I have to use which suture? Vicryl suture. Suppose I am doing with a ureter, dealing with a case of ureter, there also there is risk of stone formation. Again I have to use a Vicryl suture. So whenever stone formation is an issue, I can use a Vicryl suture. Now I have already told you these are absorbable sutures. First one is catgut. How it is getting absorbed? Enzyme degradation, phagocytosis and enzyme degradation. Whereas Vicryl is absorbed by hydrolysis. Okay. Now coming to next one, polydiaxenon, which is nothing but PDS. Better to remember as PDS only. That's fine. Only one point I want to tell you, vertical midline laparotomy closure. What is the suture I have to use? I have to use PDS, vertical midline laparotomy. How to suture that? I have to suture with the which material? PDS, polydiaxenon. Okay. Now coming to monocryl. Monocryl, which is also called as polyglycaprone. If you can, then you remember. But what is the use of this monocryl? Monocryl is used whenever you are performing subcuticular closure. Whenever you are planning for a subcuticular suture, then you should always use monocryl. Let us quickly look into what we have discussed now. The first thing is a absorbable suture, under which first thing I have told you is a catgut suture. Whenever we want to do superficially, means superficial vessels ligation or subcutaneous tissue suturing, I have to use a catgut. Now it is a absorbable suture, catgut. How it is getting absorbed? Absorbed by phagocytosis and enzyme degradation. If it is a catgut, it is get absorbed in 7 to 10 days, or if it is a chromic catgut, within 90 days. Coming to the second one is what? Vicryl. Where we are using Vicryl? In general surgical use we can use, nothing specifically I am telling, just routine general surgical use I can use. And whenever stone formation is an issue, I should always use Vicryl. Now coming to the third one. Third one is what? Polydioxanone, which is nothing but our PDS. Where to use? Vertical midline laparotomy closure. I have to close with the PDS suture. Now coming to last one, monocryl. Where I have to use monocryl? Tell me where I have to use monocryl. Even I have also forgotten. Sorry. Subcuticular suture. I have to use a monocryl, right? Anything we have missed? Okay, Vicryl, the mechanism is hydrolysis. Okay, we have covered everything. Okay, right. Now, suture materials, actually it is a longer topic, but I have minimized and I have simplified up to an extent. If you want to remember more than this, then it's up to you. If you want, you can go through the textbook and you can remember the entire things. But the issue is whether you can remember the same thing within an exam, whether you can recover all those things in the exam and should be able to write within the exam, means it's your thought. What I want to tell you here is at least simplified version, only few things to remember and remember them in a perfect way. If someone asks you monocryl, subcuticular suture, someone asks you Vicryl, general surgical use, and whenever stone formation is a issue, someone asks you catgut, superficial tissues, subcutaneous tissue suturing, like that. Someone asks you about silk suture, vessel ligation, drain fixation, okay, and someone asked about nylon, tendon repair, nerves repair, cataract surgery. So at least you should be able to say, if you learn only few things, the chance for you to remember is much more in the exam. Okay, that is why I have simplified this topic into very small topics. Okay, very small thing only. At least try to remember this. If you want to go for extra, then it's up to you. Now coming to the next topic. Coming to appendicitis. No, the question is appendicular mass. It is not appendicitis. Appendicular mass. The patient, there is a patient who has presented to me with pain in the right iliac fossa. Okay, that too, especially, so let us take a child who has presented with the pain in the right iliac fossa. I have done examination. Ultimately, I found out it to be a case of appendicitis. Appendicitis is a clinical diagnosis. I mean, which has to be supported by even a ultrasound or a CT scan. But this case of appendicitis may, on examination, it may present to you like a mass, appendicular mass may be there or appendicular mass may not be there. Suppose there is no appendicular mass, how to manage the case of appendicitis? Obviously, you have to go for surgery, appendicectomy. Now, suppose there is appendicular mass. Suppose there is appendicular mass. What to do? If at all there is appendicular mass, I should not go for surgery. I have to do a conservative management. The name of this conservative treatment I am doing here is Ochsner-Scherner regime. Okay, Ochsner-Scherner regime is the name of the conservative treatment where I am going to do in the appendicular mass approach. So the question is, sir, you are telling appendicitis without appendicular mass, the treatment is surgery. But you are telling there is appendicular mass, but you are doing conservative treatment. What is the reason behind? What is the rationale behind this? Because inflammatory process which is there, it is already localized. Means what? Whenever there is formation of this appendicular mass is there, the infection which is occurring here, appendicitis, is already is localized. Okay. If at all I am going to do surgery, if at all I am going to do inadvertent surgery, already there is a mass. Mass is already going to localize the inflammatory process. By chance, even in mass, if I am going to perform a surgery, due to this mass, the surgery is, first thing, it is difficult. Not whenever a surgery is difficult, it is dangerous also. Because of this reason, already the inflammatory process is localized due to the mass, and now even surgery is also risky. Why? Because it is a difficult approach. Whenever there is a mass, it is difficult to approach. Because of these reasons, conservative method of treatment is a much better option for appendicular mass. Now, coming to even it may be impossible to find the appendix also. Even if you open up and you want to do the surgery, even within the mass to find the appendix is also a problem. It is also an issue. That is why better to avoid surgery in case of appendicular mass. Now, sir, you are telling conservative management, Oshner, Sherran regime. What to do? I have to do simply sitting. No, I have to do conservative management. Means I have to do management, not just like sitting there in front of the patient and waiting. No, I have to do something. What should I do? Every fourth hourly, I have to measure the pulse rate of the patient. I have to check how much pain he is going to get. I mean, whether the pain is improving or whether the pain is increasing, and what is the size of the mass, and other vitals like temperature. If you want, you can measure also. I am going to look at three things: pulse rate, what is the status of the pain, whether it is improving or increasing, what about the size of the mass, whether it is increasing or not. Suppose the patient is improving, on suppose every fourth hourly I am checking this, and within 24 to 48 hours the patient is showing improvement side. If the patient is on the side of the improvement, what should I do? Simply I have to discharge the patient. By chance, if the patient is not improving, pulse rate is increasing, pain of the patient is also increasing, not only that, increase in the size of the mass is also there, then this is a case of appendicular abscess. This mass has become an abscess. Appendicular abscess. Now, how to, suppose the patient is improving, I send the patient home, but I have to perform a interval appendicectomy. Means at a later time I have to perform appendicectomy. Okay, appendicectomy I have to do. In every case, no. If and only if the patient is a child, or if it is a case of recurrent appendicitis, or if it is a appendicolith. So I am checking three things: pulse rate, pain, and also size of the mass. If the patient is improving 24 to 48 hours, I have seen continuously the patient is improving, I am going to discharge the patient, and I have to perform an interval appendicectomy if the patient is child, or if it is a recurrent appendicitis case, or if there is appendicolith. Now, coming to this side, pulse rate is increasing, pain is increasing, size of the mass is also increasing, means it is a case of appendicular abscess. The appendicular mass has become now an abscess. Now, how to manage this? First thing is I have to confirm that it is an abscess. So what is the investigation I have to do? I have to get a ultrasound done. Very good. Or I have to get a contrast enhanced CT scan. I can get done. After this, what to do? Yes, I have confirmed. Yes, this is a case of appendicular abscess. How to treat this case? Abscess. How to do? You have to drain the abscess. How to drain? Percutaneous extraperitoneal drainage of the abscess has to be done. Extraperitoneal drainage has to be done. Okay, I'm going to drain. Not only draining, even if it is an abscess, I have to give antibiotics. You already know. Next. Now, okay, I will enlarge this. Now the question is, there is appendicular abscess. Now I have treated the abscess, and now I have drained the abscess and I have given antibiotics. Now the question is whether there is need of interval appendicectomy. Okay, whether should I do interval appendicectomy or not is still a matter of debate. Why? Because why? Because you have to estimate how many cases are going into recurrent appendicitis or how many cases are going towards the neoplasm side in the future. You have to assess. If the number is big, I mean different textbooks has given that differently. Some of them are telling you the incidence of recurrent appendicitis and neoplasm is increasing in case of appendicular abscess in the future. That is the reason why you have to get an interval appendicectomy. Some of them are telling no, it's not required. It's still a matter of debate, but recurrent appendicitis and neoplasm, the risk is more. Then you have to get an interval appendicectomy done. Now coming to the next question, that is Glasgow Coma Scale. GCS. I have to assess three things. EVM. What I have to assess? Glasgow Coma Scale. EVM. Best eye response. E. Eye response. Best eye response. E. Best verbal response. V. Best motor response. M. EVM. First thing I want to tell you, if you look at, I have already drawn this. If you look at this, best eye response 4321, 54321, 65431. Okay, if you see, I have never written a 0 over here. Means what? The least possible GCS score is 1 dash 1 dash 1. Means in total it has to be 3. Minimum GCS has to be 3. Write it down. What is the minimum GCS? It has to be 3. What is the maximum value of the 3 means what? Obviously 1 dash 1 dash 1. What is the maximum? 4, 5, 4, 9 plus 6, 15. So the maximum count has to be 15, which can be written as 4, 5, 6. So the minimum value of GCS is not 0. It has to be 3, 1 dash 1 dash 1. The maximum score is 15 out of 15. Now we will look at individually. Eye response. Eye response means when to give 4 out of 4 to this patient. If the patient can open the eyes opening, if he is able to spontaneously open the eyes opening spontaneously, then I can give 1. I can give 4, sorry. If there is eye opening but in response to pain, so I have given a painful stimulus. Only to a painful stimulus, if he is opening, sorry, cut this. So First, when to tell 4 points if he can open the eyes spontaneously. When to give 3 points if he is opening eyes to speech. Means if I talk something, the patient is going to have a eye response. He can open eyes when I am talking to speech. Then 3 points. Now he's opening eyes to pain. Then 2 points. If it is no eye opening, if there is no eye opening, then I have to call it as a 1. So eye opening is divided into 4. Okay, the first thing is if we can open the eyes spontaneously, then it is 4. If he can open the eyes only to speech, then it is 3. If he can open the eyes to pain, then it is 2. If he cannot open the eyes at all, it has to be 1. Okay. Now, I want to ask you a simple question. There is a patient. He is able to open the eyes to speech. He is able to open the eyes to pain. What is the score I have to give? Please remember, always give a much better mark. Means whenever he is able to open the eyes to speech, I have to take it as 3 only. Why should I go for a next one to pain? If he cannot open the eyes to speech, then I have to check for the pain. Then the score has to be 2. If anywhere if it is mentioned that he is opening to speech also and he is opening to pain also, then your answer has to be for I, the score has to be 3. It should not be 2. The best response you have to take. So that is why I have wrote here best eye response, not eye response. It is the best eye response. Okay. Now moving ahead. Coming to the verbal response. What is this verbal response? If he is able to talk perfectly, means he is oriented, I have to give a 5 score. If he cannot talk at all, then I have to give a score of 1. He is somewhat confused, I have to give a score of 4. If he is talking he is able to talk but some inappropriate words, then it is 3. If it is incomprehensible words, if he is talking, then I have to give a score of 2. 5 means oriented, 4 means confused, 3 means inappropriate words, 2 means incomprehensible words, 1 means he cannot talk at all. Now coming to the best motor response. Same thing I have to do. Highest for 6, least for 1. Means if there is no motor movement, then I have to write 1. If there is the best motor response, means whatever I am asking him, lift your hand, lift your leg, he is obeying and he can able to do, it is 6. If he is localizes to pain, then it is 5. Then if he cannot localize but he can withdraw to pain, then it is 4. Flexion to pain is 3. Extension to pain has to be 2. So out of these 3, somewhat difficult to remember is always the best motor response is somewhat difficult to remember. Otherwise, eye opening is very easy. Spontaneously is 4. To speech is 3. To pain is 2. He cannot open the eyes, it has to be 1. Coming to the verbal response, oriented is 5. Confused is 4. Inappropriate words 3. Incomprehensible words 2. He cannot talk at all 1. Coming to motor is somewhat difficult. Why? Because if he obeys all the commands, then it has to be 6. If he is talking none, then it has to be 1. Between that we have to remember somewhat. Localizes to pain 5 and withdraws to pain 4. What is 3 and 2? 3 is flexion and 2 is extension. So in some textbooks what they give is, if the patient is in a decorticate rigidity, if the patient is in a decorticate means what? Flexion. The patient upper limbs are in flexion. So if they talk about decorticate position, decorticate rigidity, then please take it as 3. If at all they tell you the patient is in a decerebrate position, means what? Decerebrate, upper limbs are in extension. So if it is a decerebrate, take it as 2. Okay. Localizes pain is 5. Withdraws to pain is 4. Okay. Now coming to the next one, that is Courvoiser law. This law is somewhat difficult to explain, but I will try my best. So forget about what is written here. First you have to concentrate on what I am going to tell you. Forget what is written down there. Suppose there is a stone which is formed in the gallbladder. There is a stone. This stone can ultimately come here and it can block the pathway. If it comes here, that stone, if it is coming here, that gallstone which is formed there, after some years in the future it comes into the CBD and it is going to cause obstruction. Now what is going to happen? Due to chronic cholecystitis, what happens to the gallbladder? The gallbladder is already going to be shriveled. It is going to be shrunken. It is not going to be distended. The gallbladder, whenever you look into a case of chronic cholecystitis, chronic case, it should always be a shriveled gallbladder. Means the size of the gallbladder is always shrunken. It cannot be a distended one. Okay, but if I take another part, by chance if I take another part, means if at all there is a cancer over here, periampullary cancer, means this is around the region. If there is a cancer in this region, periampullary region, there is a cancer. What happens when there is a periampullary cancer? The bile cannot come down. Means what? The bile is going to be obstructed somewhere in all these things. Means the gallbladder, what happens to the gallbladder? Gallbladder is going to get distended. So ultimately what I want to tell you over here is, if there is a gallstone which came here and it is obstructing, it is also causing obstructive jaundice. If you take a case of periampullary cancer, it is also causing distal obstruction. It is also causing obstructive jaundice. So here also obstructive jaundice is there, here also obstructive jaundice is there. But what happens in this gallstone is, due to this chronic nature, there is the gallbladder is already shrunken in size. We can't see a distended gallbladder. But whereas in case of periampullary cancer, there is a distal obstruction, the bile is going to pile up and the gallbladder is going to be a distended one. That is the reason why, if at all you see a distended gallbladder in a case of obstructive jaundice, do not think of gallstones, always think in terms of a periampullary cancer. Just I will read out this sentence for you. In a jaundiced patient, if the gallbladder is distended, it is seldom due to a stone in the CBD, because in such cases gallbladder is already shriveled. Okay, why this is jaundice is due to? This jaundice has to be due to periampullary cancer mostly. This is what Courvoiser law is. But there is a fallacy to Courvoiser law. What is that? Primary CBD stone. Suppose there is a stone which has formed directly in the CBD. What happens if there is a stone formation directly in the CBD? It has not formed in the gallbladder. It has directly formed in the common bile duct. Now what happens? Same, similar to the periampullary cancer, there will be bile. There will be collection of bile. Due to the collection of bile, will there be gallbladder distension? The answer is yes. That is